So our first presentation has been started by Dr. Carlos Robles-Medranda. He's head of the endoscopy division at the Ecuadorian Institute of Digestive Disease, and he will be sharing his expertise and experience about advances in endotherapy for the management of obstructive chronic pancreatitis.
Good day, everybody. Thank you for this invitation. I will talk about the advance in endotherapy for the management of obstructive chronic pancreatitis.
This is our first talk.
This is my disclosure. So I would talk about the indications of endoscopic intervention in chronic pancreatitis, current endoscopic therapeutic strategies, and emerging endoscopic therapeutic techniques. The educational goals of this presentation is to discuss the indication for endoscopic intervention in chronic pancreatitis, to evaluate current treatment options, to address treatment of complicated patients, and new endoscopic method tools as radiofrequency guided by US for neurolysis for pain management, US guided management of pancreatic duct structures, and US guided management of duodenal stenosis. So what to do in complicated or refractory patient in chronic pancreatitis? So as definition, we need to understand that significant persistent pain post-intervention is defined patients with complicated chronic pancreatitis, high-risk patients with poor general condition. There is no clear consensus about the treatment or what to do in this kind of patients. A favorable prognosis to invasive treatment associated with pancreatic morphological change and pain, there is a temporal treatment, early surgery associated with diminish of reintervention, diminish of pancreatic insufficiency, and improving or complete pain relief. And when narcotic use of or dependence of these patients with central sensitization diminish the outcomes. What are the indications for intervention in chronic pancreatitis? Patients with persistent continuous severe pain more than 3 months with or without exacerbations, pain related to ductal morphology, pain with more than 3/10 with impact on daily life, and when the medical treatment is not susceptible. What kind of interventions in chronic pancreatitis do we have until now? Or what we can do is to use extracorporeal wave lithotripsy. It's a valid option, not available in all centers. However, we have surgery also in some certain cases, as we will discuss in the next slide, and endoscopic therapy for the treatment and management of these patients with chronic pancreatitis. What is the endoscopic approach? What is the main objective of endoscopic approach? Is to have a duct, main pancreatic duct decompression related to a stone extraction, and this also can help in the pain management of these patients. The endoscopic approach is also used for refractory pain management, and nowadays we have other emerging techniques for other kinds of situations in these patients with chronic pancreatitis. So as endoscopic techniques, we have all nowadays the celiac plexus block, that is neurolysis for pain management, through ERCP, using lithotripsy for stone extraction, stenosis dilation, and drainage with plastic stents. We have biodegradable stents nowadays, and we have lungs also that we can use for these kind of patients, and US guided management using microforced biopsies and confocal laser under microscopy for diagnosis, antegrade drainage for alterate anatomy. We can use it also, and gastrojejunal anastomosis for the management of duodenal stenosis is certain kind of new techniques that we can use in some cases when we have stenosis in the duodenal part, and we need to treat these patients. So I will start to talk with the endoscopic management of the stones. So this is the first line therapy nowadays is without doubt the use of um, um, lithotripsy and stent placement. So we can do endoscopic removal of the small calculed stones and fragments. And as new technology, we have pancreatoscopy with EHL intraductal treatment of this stone. So this is interesting case using an eye French cholangioscope inside the pancreatic duct. You can see here the treatment that we can do using lithotripsy, and it's one of the methods that we can do nowadays. So here you can see the lithotriptor here, and we are doing a stone removal of this biggest stone in this patient with chronic pancreatitis. And also, it's very important to evaluate once we arrive to clear all the main pancreatic duct, to evaluate the rest of the main pancreatic duct to see if there is any kind of lesion that we can miss in some of these patients. Because uh, the probabilities to have IPMN with chronic pancreatitis is reported in some cases. What about the endoscopic management of stenotic lesions and obstructions? So for pain relief of the obstruction and the treatment of these stenosis lesions is very important. So the first line is endotherapy over surgery overall in high-risk patients. If surgery is contraindicated and therapy fail or complicated cases, US-guided drainage is another alternative to these patients and to this management. The stent patency is around 6 months, and ERCP inserted stents should be removed and exchanged every 2 to 3 months. And we can use nowadays also lamps for persistent structures in some cases. In distal main biliary duct obstruction, endotherapy can solve the jaundice of these patients, and is indicated if we have patients with obstructive jaundice and acute cholangitis, cholestasis with phosphatase alkaline elevated more than 2 or 3 times over more than 1 month, even if the patient is asymptomatic. Biliary stent placement is recommended for 6 months to 1 year. LAMS is also feasible as treatment, the placement of this kind of new stent. And covered metal stent replacement time is unknown until now. Surgery is indicated if the biliary duct obstruction reoccurs after 1 year of post-stenting. And when we have a lot of calcifications in the pancreas, or if we have a mass on the head of the pancreas, if this is associated or not to this kind of condition. So it's very important to understand that many of the patients that have a lot of calcification in the whole pancreas and are not located just in the main pancreatic duct, probably these patients need a surgery or resection. What about the stenosis? The treatment of the treatment that we do for now is partial pancreaticoduodenectomy. It's imperative. Moreover, if we have the need to exclude a cancer lesion in these kind of patients. We have also nowadays new endoscopic tools as the Siemens duodenoscope. This is interesting case that we have in our unit recently is 53 years old male with D3 stenotic lesion. So the distal duodenal, we do a distal duodenal dilation, keep it during ERCP and using this new ERCP, new slim duodenoscope for ERCP. The outcome was a symptomatic relief with no post-procedural complications, and we arrived to do procedures, biopsy, and also to put the stent in case of patients that require. For example, here you can see here also this was a stenotic area because of patient with chronic pancreatitis in a mass. So we arrived to perform using this slim deck of this 3.2 working channel and 12 millimeters of diameter in distal part. So we arrived to do the whole procedure just with this new ERCP tool. So the advantage of this new duodenoscope is that we have high definition image quality. So we have also an appropriate maneuverability. The advantage to have a disposable elevator cap diminish the cross-contamination and lets us perform easier reprocessing. We can do a precise therapeutic performance, especially in ERCP procedures. However, some limitations is that we can use just digital single peroral cholangioscopy only with 9 French scopes. This is a very interesting case. In some cases, we need to have to pay attention because we can have patients with chronic pancreatitis and IPMN history. This is a case of our unit, a 64 years old male with failed ERCP due to stenosis in other center. So the patient presented with history of chronic middle abdominal pain and unintentional weight loss and jaundice for 3 months. So at the endoscopic ultrasound, we observed an hypoechogenic pancreatic head lesion with dilation of the main pancreatic duct and main biliary duct. So these are the image of and the video of the case. Initially, we have this collection at the beginning. For sure, we think about pseudocysts due to chronic pancreatitis, and we arrived to do some drainage of these areas, but we perform 1 week later one virtuoscopy through the lungs because of failure of the ERCP, and we didn't arrive to, you see here the classification, we didn't arrive to pass this area with the ERCP and the standard ERCP. So we start this approach through the lungs, and we arrived to detect an IPMN, as you can see here. So once we went through the tail of the pancreas, we saw this this calcification due to the chronic pancreatitis, but we also identified the presence of IPMN in this patient. In spite of that this patient becomes better after the treatment, we sent this patient to surgery because it was a formal indication due to the IPMN of the main pancreatic duct and chronic pancreatitis in this patient. What about endoscopic drainage? So nowadays we can arrive to do gastroduodenostomy in patients with gastric outlet obstructions related to chronic pancreatitis. So this has been published in 2015, and the technique is really the approach is easier. It's just to identify the small bowel through the gastric wall, and to perform anastomosis, we can, I am showing here in our case. Regarding the treatment of pancreatic pseudocysts that could appear in this kind of patients with chronic pancreatitis, endoscopic transpapillary pancreatic stent can be performed in patients with pseudocysts with less than 5 centimeters and a main pancreatic duct communication. In asymptomatic pseudocysts with more than 5 centimeters and with a persistence of more than 6 weeks, transmural drainage is also is a formal indication. And if patients have pancreatic duct structure with alteration on CT scan or MRIs, ERCP with a stent before drainage of a small pseudocyst is large, the pseudocyst transmural drainage should be the first election. Endotherapy fails, so and repeated therapy needed in this kind of patients. Surgery resection is a formal indication, and nowadays we have also US guided transmural drainage. It's safer than other techniques with LANS. So this is a case with the pseudocysts due to chronic pancreatitis, as you can see here. So we arrived to do the drainage, and the management of this patient was just the patient was just relieved with this drainage. Again, in this case, we identified the existence of an IPMN. So in those cases, as I already mentioned, needs to send to be evaluated and treated by surgery. So this is a study that was recently has been recently accepted for publication from our series with more than 120 pancreatic cysts, where we demonstrate that the US alone is not superior to US and confocal as well as micro forces biopsy through the needle for identification to purely identify this kind of malignancy coexistence in this kind of patients. So there is also a meta-analysis recently published in GI endoscopy, where new technologies can help us to distinguish this kind of patients. So finally, I would talk about endoscopic management of post-surgical complication in these cases. So we have new biodegradable self-expandable stent as well as plastic stents. So we can use as a new therapeutic approach for fibrotic pancreatic duct structures management. We can have continuous calibration, higher dilation force, large diameter, and so the degradations occurs after 3 to 6 months and no migration risk in this kind of patients. So this is an example of how we can deal with patients after surgery that have complications. So this was a patient that had a surgery because of chronic pancreatitis, and we arrived to do a US guided drainage using first plastic stent, double pigtail, and then we take it again the patient after 15 days when the fistula is already the patency of the fistula is already available. So in these cases, for example, we use a biodegradable metallic stent to do a calibration of this stenosis, post-surgical stenosis in a patient with chronic pancreatitis. So there are some small results in the literature in 2018 in 19 patients. So the success placement was 100% with adverse events in 21% of the cases. in case of complete dissection of the main pancreatic duct. So we can perform, drainage of the cellulocyst, and at the same time, it's very important and necessary to use plastic stents or biodegradable stents inside the main pancreatic duct to, close the amount of liquid from the pancreas to the cellulocyst in case of chronic pancreatitis. What about management of refractory pain? So we know very well that we can do celiac plexus blockage and neurolysis. So the standard technique has shown during many years that the relief in this kind of patients with chronic pancreatitis and pain relief in 51 to 59% of cases. And however, we can have increase of the pain due to neuropathic pathology later, and we can have also adverse events as hypotension, hemorrhage, infection, and neurological complications. Recently, we can do radiofrequency. This is a very interesting report using radiofrequency for celiac ganglion ablation using RFA, and the results appears to be much better than the standard technique using neurolysis. This is a case for unit with chronic pancreatitis and abdominal pain that was managed using radiofrequency. You can see here the needle inside, and the effect is very similar to the neurolysis, and this patient arrived to have a control of the pain. Regarding new technology, so in the future we will have the fusion technology to use more accurate therapeutics using the CT scan and endoscopic ultrasound image to do treatments, target treatments in these patients. Also, nowadays we have adaptable US systems to a standard scope. So this could be very interesting to see what will happen with this kind of technology in the future for the management of patients with chronic pancreatitis. In summary, the endotherapy advantage is that our minimal invasive, no scars, ambulatory management may allow to delay or even preclude surgery with organ preserving endoscope techniques, less morbid mortality and cost effective. In conclusion, new available endoscopic methods and tools provide a minimal invasive approach for the management of chronic pancreatitis and its various complications. Treatment through these novel endoscopic procedures may allow to avoid unnecessary surgical intervention and prolonged hospital stays while providing adequate pain relief. These are the references. I would like to say thank you for this invitation and this opportunity. It's for me an honor. I would like also to invite to our live course that will be in August online. Please stay with us and follow us in our live endoscopy channel in YouTube. Thank you so much.